I think we're live on Facebook again.
Okay, let me see. So are we on Black Doctor or not?
No, I don't see us.
Okay. I'm on Ricky's page.
Hey, everybody. The doctor is in. I'm here with my ladies, Dr. Mo and my two breasties who are trying to figure out if we're online or not. And we are, you guys.
Where? Oh, here it is. I see it, but I don't.
Carrie, we're online, everybody.
Hi. Hi, on what page? So I can let my people know.
blackdoctor.org. So we need to everybody focus. Dr. Mo, how are you doing tonight?
I'm doing well. As soon as I can share this live with everybody.
We are on. We're always having a few technical difficulties, you guys. Sorry for it. We're always late getting started, but we're trying to get it together. And it gets better. I don't know if it gets better every week, but I'm here with Dr. Mo, and we have two of my favorite breasties, Terry Lynn and Tallulah.
Hello.
Talk about knowing your HERstory, the importance of knowing your HERstory. So you guys want to introduce yourselves real quick?
Sure. Hi, everyone. I'm Tallulah Anderson. I am a 3-time breast cancer survivor and founder of 2 for 2 Boobs, and I have the BRCA2 gene and a unique family history.
Blackdoctor.org. So we need to everybody.
Now you're gonna have to turn your volume down. Yep, there we are.
Tallulah?
Yes.
Introduce yourself.
Oh, reintroduce? Okay. Again, Tallulah Anderson. I am a 3-time breast cancer survivor and the founder of 2 for 2 Boobs, which is take 2 minutes to check your tooth. And I have the BRCA2 gene, which is a genetic mutation. And I have a unique family history that I'm excited to share today. So thank you for joining us. And I'm excited to be here with these lovely women.
Great. And I think we lost Terry. Hopefully she'll get back on. But
fantastic. I'm Dr. Monique Gary. I am a breast surgical oncologist and medical director of the cancer program at Grandview Health in Sellersville, Pennsylvania, just outside of Philly. I am pleased to join you tonight. And this is a really important topic. So tonight we are going to talk about genetics, a little bit about genomics, the difference between the two, and why it's important to know your family history. So as we wait for Terry to join us again, there are some key things that we probably should go over in terms of statistics. So this is the technical part of the conversation. But
after most school us.
All right, well, let's make it simple. You know, I believe in saying things that people can understand easily. And all cancer is genetic. Let me do this and look into the camera. All cancer is genetic, but not all cancer is hereditary. And so there's a difference between something that is genetic and something that is hereditary. So for the people who are over the age of 40, 45 on up on my timeline and on Black Doctor, you will understand this analogy, but I give the example of I Love Lucy. Okay, so there's an episode where she and Ethel work in a chocolate factory and the machine goes haywire. The factory goes crazy and the chocolates start coming off the belt faster and faster. You've seen that episode, right? Everybody loves that episode.
Yes,
right.
Yes.
So the chocolates are coming faster. They're stuffing them in their pockets. They're stuffing them in their mouth, their apron. That's cancer. The cells grow faster and faster until a tumor forms, and that's genetics. But the hereditary component is if that factory mistake then gets passed down generation after generation after generation. That's heredity. So all cancers are genetic in that the cells make a mistake. They either don't die when they're supposed to, the telomeres are too long, they don't, whatever the mechanism is that's supposed to signal a cell to die because it's mistaken, doesn't get signaled, the cells live, they reproduce. That's genomics. So genomics is really going to be more like the study of the DNA sequencing and the gene expression differences between tumor cells and normal host cells. So what's different in cancer cells versus normal cells? So genetics, we're starting to talk about heredity. We're looking at how genes get passed down, how they get activated from one generation to the next. Genomics is looking at the tumor cells themselves to look for mistakes within those cells. Does that make sense?
Yeah. Did you get that, Tallulah? Did you understand her?
Yes, I did.
That's the simplest explanation for those people who are watching. And it matters because, you know, when we talk about the highest risk for cancers, and let's use breast cancer because we know our breasties are watching. The highest risk for breast cancer is found in those people who have hereditary mutations in BRCA1 and 2. So you're talking, you know, something like in an unaffected person, up to 87% lifetime risk for breast cancer, up to 60-something% risk for ovarian cancer, and not to mention the whole syndrome of cancers that BRCA is associated with. And Tallulah, I know you know this all too well, right?
Yes,
because it's HBOC, right? Hereditary breasted ovarian cancer syndrome. But do we also know that men who have the BRCA mutation, Beyonce's father, are at increased risk for breast cancer. Men are at increased risk for prostate cancer. And melanomas as well can be associated with BRCA mutation. So there's other genes, because if a cell's going to make mistakes, who's to say that it just makes a mistake in that one system, right? If it's programmed, if the spell checker is faulty. And that's really what these genes are. Cancer genes like BRCA1 and 2, and Terry will come on, she has a mutation in the Fanconi gene. And so those genes are gatekeepers. They help to keep the body and the cells from making mistakes. So if your spell checker is faulty, then you will put out cells that are faulty because the gatekeeper is messed up. And so that's what happens in these mutations. And those people are at increased risk. The tricky part is who's checking for those folks? Who's checking for them in people of color, right? And so there's a lot of data that's emerging. There was an article that just came out about, I want to say about the 15th or the 19th of May. It's one of the larger studies that came out of the ASCO journal that looked at about 5,000 Black women. And it looked to see who had been tested, and it went on to test those women. And so what's really interesting is that what they found was that Black women have about the same rate of mutations in BRCA1 and 2 than white women, which is interesting because we know that the rates of breast cancer, the rates of more aggressive breast cancer, we should say that, the rate of more aggressive, more advanced breast cancer is higher in Black women.
Say that again. Say that again.
A rate of more aggressive, later diagnosed, later stage breast cancer is higher in Black women. When you look at the overall numbers of who gets diagnosed with breast cancer in the country, white women still get diagnosed more. Let's say that, you know? So the rate of who gets breast cancer, we're not the highest rate of who gets it. We are diagnosed later. We are diagnosed with more aggressive cancer, right? But our BRCA1 and 2 mutation status is about the same. So what does that suggest? It suggests we need to look at more genes in BRCA1 and 2, right?
Absolutely.
Exactly right. Entree Terry Wade, tell us about yourself.
So my grandmother had breast cancer. I have the BRCA1, BRCA2, as well as the FANC mutation that everybody could explain to me that BRCA1 and BRCA2, but nobody could explain to me this FANC mutation. So I was invited for up to Philly for the LBBC and literally ran into you coming off the elevator. And what I have been trying to figure out for months, 2 seconds. Oh, this is this, bam, 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 this is what you do. But it shouldn't be that way. You know, the oncologist and the hematologist and breast surgeon, everybody my whole team, nobody knew about this mutation, which is scary and whatever is after scary. Nobody could tell me what it was about. Excuse me. And then after speaking with you, Dr. Mo, you were telling me about this mutation, and everything that you were saying was exactly how I was feeling. I was always tired. My iron level, I couldn't figure out why my iron levels weren't moving, or it was everything tied around that mutation. So that's frustrating within itself. And if I didn't, even though I have the family history, breast cancer was new to me. You know, it was new to my aunt when she was diagnosed a few years ago. And the answers that I needed, if I didn't know Tallulah from work, if I hadn't been introduced to Ricky at a fashion event, I just would have been like, okay, what do I supposed to do? You want me to do 6 rounds of chemo? Okay. And then what? Everything I needed to know, I got from Dr. Gary, Ricky, and Tallulah, and some other ladies. But there needed to be a better tracking, and we need to do something better to help women who have these unusual genes. I don't know how we can do it. What are you doing with your patients who ask for more information? You just saturate us.
Go back a minute. So Dr. Mo.
Yeah.
Not every patient even does gene testing.
So not every patient is offered gene testing, and there's a reason behind that. But I want to back up to what Terry said. I remember that meeting. You know, I just finished giving a talk, and I was on my way out because I had just flown in from Lisbon, Portugal, at another meeting. And the backstory that you may or may not know, Terry, is that I've got family history. So my mother was diagnosed with ovarian cancer at 29, and she died before 30.
Wow.
My grandmother had breast cancer in both breasts. And so when we talk about high risk, I sit at that intersection. And so it's always been of interest to me. And when I finished my fellowship, I came to a place where 40% of the women in my community where I practice were not even getting screening mammograms. And 1 in 4 had a potential first-degree relative with a hereditary cancer. So breast, ovarian, melanoma, prostate, pancreatic, colon, gastric. Right, the cancers that tend to run in families that are associated with gatekeeper genes. So I got to this community and I said, well, where's your high-risk program? And they said, what do you mean? And I said, well, what do you do for the people who don't have cancer yet, but have family histories and have mutations? Well, if they get cancer and they're young, we send them to so-and-so.
Lulu's having trouble over there, honey.
I'm sorry.
That's all right. You can mute if you need to.
Okay.
But you can, where is the place for these people, you know, and who's housing them, who's looking after them, and what happens if they get cancer, you know, what's the mechanism for these patients? And there wasn't one. So if they met criteria and they were young, 45, breast cancer, they'd send them to a counselor and get tested. But what about their daughters? What about their sons?
Absolutely.
What about their sisters? So I started a program. I'm the director of the high risk program at my health system because of that, because I needed to know what we were doing for people like me, you know, who were at high risk. And so I'm very fortunate to have had that education to be able to share it with you.
Absolutely.
Fanconi's anemia. So she's saying a FANC, F-A-N-C. It sounds like you're saying fake or fang, but F-A-N-C is the mutation.
It's the southernness.
No, it's not. It's a weird word. Like, who says it, you know? And so there's 13 different mutations in Fanconi, 13 different genes involved in that type of anemia that you have. And one of them is identical to BRCA2. And so that's why the breast cancer, that's why it's in the families. The anemia is why you're tired, etc. So Ricky, to your question, there are different guidelines for who should get hereditary cancer testing. And the guidelines over the last two years have exploded, because previously you'd only get tested if you were under the age of 50 and you had 3 or more relatives on one side of the family with a different, you know, certain type of cancer. So let's say breast cancer, 3 or more relatives on mom's or dad's side. Yes, dad's side does count. Yes, it does.
Right.
If you had triple negative under 60, and that was it. And Medicare wasn't really covering it, and everybody else was, you know. So what happened to all the people who had breast cancer in the 80s and in the 90s and in the 2000s who weren't offered the genetic testing? The BRCA genes weren't discovered till 93 or so, right?
Correct.
So,
and I believe, so Dr. Gary, not to interrupt you. So
please,
what about, so in my case, I had my first tumor removed from my left breast when I was 10. 9 or 10, and it was 10 centimeters. So that was so long ago. And it's unfortunate that at some point, the technology has changed and everything, of course, but I would love to see, like you're saying, moving forward. I don't have any daughters. I have a son, and I have he just had a little girl. So naturally, I'm concerned about his breast health, as well as Aria's breast health. And then my Aunt Maria, she has a son and a daughter that are both in, 19, 20 years old. Mm-hmm. So there, other than the program that you have in Philadelphia, and correct me, Ricky, if I'm wrong, there's nothing like that here.
There should be.
For two boobs.
I think we should let Tallulah tell her story, because she's got a story with men involved. So let Tallulah tell.
Right.
Tallulah's on mute. Uh-oh. I did this. That's my fault. Tallulah, unmute yourself.
I'm sorry. I was diagnosed the first time in 1998. And during that time, my doctor, who was a great doctor, Dr. Alley, who's retired now, recommended that I go to Georgetown and be part of a study for the BRCA genes. And she knew that to do this because as I mentioned before, I have a unique family history. My mom had breast cancer and my dad. So it's both sides of my family. So when you say it can happen to men, yes. So I have 7 brothers and 3 sisters. From the 7 brothers and 3 sisters, I'm the youngest girl. My oldest sister is a 30-year survivor. I know she's online watching. Yay, Constance. I have a sister who was diagnosed a little bit about 5 years ago. She's surviving and thriving. Her name's Denise. She's online too. And I have another sister who tested, and she does not carry the gene. So the sisters do. I have a brother named Kenneth. He died over eight years ago. He had breast cancer and carried the gene. And I just recently had another brother test and have the gene. He's stage 0. And so my other brothers, all of them have to be tested. My son has to be tested. That's the recommendation. But I found out from being on a panel yesterday, I have the one sister who tested, who did not test for the gene, but they recommend that she get retested every other couple of years. It may not be showing now. However, if her husband had family that had breast cancer, her children should be tested for the gene.
Okay.
So there is, and also there's a big testing study and testing group going on now in Virginia. And that's what I was on yesterday, and I can share that later. But Georgetown University has been doing this study for years. And if you have that family history, the insurance in this area, most of the insurance in this area will cover it.
And the DPA
cover what? The testing?
The testing.
I think that's a really important point. Go ahead. I'm sorry.
Absolutely. I'm sorry. I don't know how true that is with the managed care programs through the state funded insurance, because that was my problem. When I went for, when I was getting ready to have my prophylactic mastectomy, we lost our contract, Tallulah, if you remember, and I was forced to go on to state funded health insurance, and they would not test me. They would not give me the tamoxifen as a preventative measure, and they sure weren't going to allow me to have both my breasts removed. So for that time, I'm fighting with this managed care organization through Maryland Medicaid, fighting. Then I get a job full time and get tested, get the genetic testing. But guess what? By the time they did the biopsies, I'd already had cancer. So a lot, it's sad, sometimes for whatever reason, we have to be on these types of insurances. We don't choose that, unfortunately, but
so
there needs to be, what I remember, I'm sorry, Tallulah, when we were at Family Choice, that was what you did. That was your thing. If we've advocated, made sure women could get their mammogram. We did everything we could do, but then there's still that portion of the state that are like, okay, short of having stage 4 breast cancer, the stage 0s or the DCIS 1 and 2, they don't want to hear that. If you don't have full-blown stage 4, 1 foot in, 1 foot out, they're not dealing with you. They're not trying to help you do anything. They want to, oh, well, let's give you some chemo for a little while. The option of having your breast removed prophylactically through these managed care organizations is non-existent, and they don't want to put you on anything unless you have a diagnosis. They want you to wait until you get the diagnosis.
Right. And you're absolutely correct. And I will correct myself and say most insurances. However, it was good to hear yesterday that there is a group now in this area who is prepared to fund for screenings for low-income women who don't have insurance, and provide some preventative care. So that's a good thing. Now that's one that I just heard of, so hopefully more will follow. But I will mention that I have a brother in Pennsylvania. When he went to get tested, his insurance did not want to cover it. So
his private insurance.
Yeah, his insurance, yes.
So let everyone know that we're in the DC area.
And we're in the DC area.
All right, let me jump in. Let me jump in. Let me get in. It's like double dutch. Let me get in here. So, Terry, I have to question when that was for you, because the guidelines that govern who gets tested and what insurance is covering now has expanded exponentially. So even just
go ahead.
What year? No, what year?
Tallulah, when did Family Choice close?
Gosh, you asked me hard questions. So that had to be around 2018, 17. Yeah, around 17, 18,
okay.
Yeah.
Okay.
Right. So it would have been
not that long ago, right?
No, ma'am.
But,
no, ma'am.
To the best of my knowledge, and I have patients who are on all 15, insurances. 15. There are companies that will almost write off the cost of panel testing, hereditary cancer testing. So, from a $4,000 panel down to a $200 fee, a $100 fee, a $99 fee for panel testing, and sometimes a free fee altogether, especially with COVID and with what's happening with people's insurance right now. I can pretty much get genetic testing, a panel of testing, almost written off for most patients as of, the last year and a half or so. So things are getting better on that horizon. And the tricky part is that we need to start talking about going back and testing those people who either couldn't afford it, whose insurance wouldn't cover it, or who weren't offered it. So we gotta backtrack, and we'll come put a pin in that one.
Right. Right.
Tallulah, to your point, I know who you're talking about. Dr. Weintritt's a good friend of mine. And,
yes.
David's a good
Thank
friend.
you for calling out his name, because
I got you. I can see it. I know, absolutely. But he and I end up on a lot of expert opinion panels together. He's a wonderful resource in that Virginia area. And there are lots of resources that are available for patients more than ever. High-risk programs are popping up all over the place. Part of my mission is to help physicians set up these programs, is to educate them on how to do it and how to integrate it, not just when a person has cancer, but how do you take it to the GYN offices, and how do you integrate it with primary care, and how do you make this now a system-wide effort to catch these people who meet criteria? Your brother met criteria, Tallulah. He should have been tested, and had it been, my patient, you go in your office, you make some angry phone calls, you write some letters, and you get it approved.
Absolutely.
It's a lot of advocacy work that has to go into it sometimes. But for something like a BRCA2 mutation, when you have 2 family members, 3 first-degree family members with a mutation, there are ways.
Not only that, if you look at my family history, and one thing that they do that they do when they do the genetic counseling is do it like a family tree. They look at both sides of the family.
Yep. So
luckily, I had a family member, and I always tell people, you always have that one person in your family that keeps that knowledge, knows what Uncle so-and-so died from.
Yeah.
Great-great-grandma.
We hope we do.
Etc. So I was able to give some great information. And from that information, I always thought in my mind that it was my mom's side of the family. However, it was my dad's. And if you look at his side of the family, he had first cousins who all had ovarian cancer, sisters, and also prostate cancer. And it came to me that my grandfather and my great-grandfather, I never knew them, and they died young. So in my mind, I think maybe they died from breast cancer, or I'm not sure, or some form of having that genetic mutation that showed up in a different type of cancer. So that is good information for me that I share with my family members. And I encourage other women and men to be part of these studies. So there's a study going on now that's specific to African-American men, where they will give the free genetic testing that I have information on that I'll include at the end. That'll be part of this taping. So there are some changes coming. So hopefully it will ensure that those who are uninsured be able to take part in preventive measures, as well as counseling, as well as genetic testing.
Absolutely.
I agree, because it's almost, I can remember calling Ricky and saying, they're trying to kill me. I know this company, this MCO, is literally trying to kill me because they won't meet me halfway. I cannot get these people to understand. And I've been in the medical community, been working in the medical community for a bit now. And I've never, ever not been an advocate for myself or for another patient or for my children, but having to advocate and not get any relief, to advocate and get the door literally slammed in your face. I'm glad to see now the 2 for 2 boobs, the Dr. Monique's, the organizations that are bringing these people in. I would love to see it more in, like Dr. Gary said, in the schools, in the high schools, 9th grade, 8th grade, 7th grade, where these young girls are getting ready to start their puberty and they're developing their breasts. They don't know what to do. Maybe mom is working 2 or 3 jobs to keep food on the table. I would love to see something like that being done here.
Well, I love that you said that.
Everywhere.
Yeah, Tallulah, I did my fellowship at Georgetown. So
okay, great.
I trained with those genetic counselors who did your pedigree and who did that. So that is part of how I was able to start the program where I am. But, Terry's mentioned a lot of really important things about advocacy, and about having somebody who can explain to you when it's appropriate to start things like chemotherapy versus go to surgery, the timing of things like prophylactic surgery, even things like reconstructive options. So, in my community, we had primarily patients who had various insurance plans that were not Affordable Care Act. And so the patients who had certain insurances couldn't meet with certain plastic surgeons for a while. And we had to do a lot of work to really get equal opportunity for reconstruction, for genetic testing, for all of these things. And so the beauty of where we are now is that the floodgates are opening very, very wide, and the key though to what you're saying, Tallulah, because what I heard you say was this: somebody in my family was a historian, somebody was a gatekeeper. Can I tell you that every family doesn't have that? People who are watching right now, I can tell you from personal experience, I didn't find out what my mother died from until I was almost 29. Right. And it was something down there we didn't talk about, right? How many of us, our family members know the difference between cervical, uterine, cervical, uterine, and ovarian cancer? Right. We just know it was down there, but we don't know what was on dad's side. And so it's so important. I say there's 2 things that we don't talk enough about in our families in the Black community. The first is money and the second is health. Or the first is health and the second is money. The 2 things we don't talk about, right? Are things that we need to be talking about. We need to know our family history, as well as we are able to trace our lineage back to as far as we can. When we go to our family reunions, you know how we see that tree on the shirts? Because my family has a big tree, and so and so got such and such, and this is their children, and they had 5 kids. Well, guess what? start putting a little something next to them. So-and-so had hypertension. So-and-so had breast cancer. So-and-so had uterine cancer, prostate cancer. You know,
just like keep those
secrets.
Yeah, and like you said, those secrets. And you know, for me, I share as much as I can with everyone. And it's like, tell your story as well. And and communicating your story with your other family members, it may spark something. And I understand that some people don't have close families, or they don't have that person that they can speak to. So that's why you have to be diligent in getting in there and getting your breast, you know, doing breast exams, getting your mammograms, getting your screenings. And if you feel something that doesn't feel right, go in and advocate for yourself. If one person tells you no, go to another and to another. You have to take charge of your health. That's what I did, and that's what I tell other people to do. And it's important that if you have sons and uncles and brothers, that they understand that men can get it too. They think they can't. And there needs to be more done to educate men on this subject matter, as well as male breast cancer, because they're lacking in something. You know, it's hard to get a man to go to the doctor anyway. And my one brother, he doesn't. When he had to go in to get a sonogram, he wanted to leave. He was like, it's all these women here and they're staring at me and they got pink gowns on. And, you know, he had to sit there and he just felt a certain way. And he doesn't like the fact that, you know, people are touching all over him. It's a whole psychological thing going on. With him, to this point that, you know, after they did the surgery and, you know, they recommended radiation, he doesn't even want to do it. He thinks, you know, it's done, and, you know, you can't tell him anything.
Well, if you need somebody to talk to him, let me know. I have a number of locations. And the thing is this, with things like BRCA1 and 2 mutations, because not all genes, when we talk about these genes and genetics, not all genes confer the highest risk. Some genes are what we call moderate penetrance, meaning if you have the gene, you may or may not express it. Some are high penetrance. If you have the gene, you will express the cancer. Things like BRCA1 and 2, especially in men, the risk for breast cancer in their lifetimes anywhere from 0 to 8%, right? Which means that about 92% of men won't get breast cancer and they have no ovaries, which means that they have mutations and they don't know it, and they have children and they pass it to their sons and their daughters. And then their sons may not get breast cancer. They may get prostate cancer and nobody thinks to check them for it, but they get their sons, you know, don't get breast cancer. They have no ovaries. They have daughters. Boom. Now we're 3 generations. And so this is why it's important to test the men in the family. This is why what happens also on the paternal side of the family matters, and why it's important to ask, you know, what did so-and-so die? What did Nana die from? What did she have? Was it this or was it that? You know, and so getting that information is so, so vital. And it is tough for a man, you know, so I have another hashtag that I use. It says hashtag check your chest. Right? Check your chest.
Right.
Well, it's important to check your breast. Guess what? Even gender non-conforming, non-binary, trans, everybody's got mammaries, right? We all have nipples and mammary glands underneath of those nipples, at least 2, sometimes more, because there is such a thing as supernumerary nipples and people have extras, right? You need to check those too. Right. So for men, I want to ask you, Tallulah, and I want to ask you, Ricky, what kind of campaign do you think would be effective for men? What should we be doing for men?
Well, you wonder when Matthew Knowles came out and talked about his situation, if it had any men do anything. I think, you know, as Tallulah mentioned earlier, men don't always go to the doctor, and Black men are dying of prostate cancer unnecessarily because they haven't checked their PSA. So I think actually, I'm sorry, it's got to come through the woman.
Right.
Absolutely.
The woman.
And I think you have to use, Ricky, I'm sorry to cut you off. You have to use, like you mentioned, Matthew and Richard Roundtree.
Right.
I had the distinct pleasure of meeting Richard Roundtree years ago when I worked for BET. And he was here in Washington, D.C. for something, and me and my friend was there, and I was like, oh, there's Richard Roundtree. And usually, you know, working in that industry, you know when to not go and, you know, bother an artist or, you know, or leave them alone. And we went over to him and introduced ourselves, and I started telling him about my dad, and he was really talking about his journey and how passionate he is about educating men. Actually gave me his email, and I lost it. But he was really, about really telling his story. I think if more and more men, if there's a campaign that includes, and these are cool looking men, not, macho looking men, right. And, using that, going from that standpoint where it's not like a breast thing, it's a chest thing, it's about strength, right. It's about taking control. I think that would be like a way to start kicking it off. Yeah.
I'm sorry, something along the lines of real men wear pink. Real men get their breasts checked,
Yeah.
I love that.
I do think though,
excuse me,
be the biggest influencers on men. You know what I mean?
Like, absolutely.
Your husband.
Absolutely.
So go back for a minute, because we're talking a lot about genes.
Yep. Bless you.
Bless you.
Thank you.
Breast cancer, it's not hereditary. Right? So for me, I have no mutations on my genes. My mom was diagnosed with stage 0 breast cancer probably 10 years before me. But we don't really have any other history in our family. And I just want to be clear. I don't want people to walk away thinking that if they don't have gene problem, that they won't get breast cancer.
Oh, yeah. That is right. That it couldn't be further from the truth. I agree, Ricky.
I think that's a really good point, Ricky. We got to take it back to the numbers. So when you talk about what the average risk for breast cancer is, average risk is 1 in 8. 1, 2, 3, 4, 5, 6, 7, 8. One of those people is getting close to 1 in 7. If you have had a biopsy in your breast and a surgery for anything that was atypical, anything that had the word atypia in it, your lifetime risk for breast cancer, you're considered high risk. And this is something I definitely want to talk about. High risk means more than 20%, which means 1 in 5. 1, 2, 3, 4, 5, one of us, right? And so people who are at high risk, either based on their family history or based on their biopsy history, their surgical history, are people who should be getting screened in a high risk program. You should be seeing a doctor like me twice a year, and you should be getting not only a mammogram, but every 6 months, mammogram, next 6 months, MRI of the breast. So mammograms are like TVs, and look at the density and the static, the snow on the screen. MRIs are like going to the 3D IMAX movie. It's the zoomed in look inside the breast. It's the closest look we have, and it's appropriate for people who have lifetime risk more than 20%. So whether it's your family history, whether it's your biopsy history, those risk factors, somebody should be calculating that risk. There are risk calculators. You can go online, you can Google breast risk calculators. You can calculate your own family history and your own personal risk based on that family history. There are 2 in particular. One is called the Gale model, GAIL. The Gale model does not take into account cousins. It does not really account for race. And so it's not the best model to use. There is another called the Tyrer-Cuzick, Tyrer, Tyrer-Cuzick, C-U-S-I-Z-K, C-K, C-U-S-I-C-K, Tyrer-Cuzick. And that one, they'll ask you about your cousins. They'll ask you when you started your menstrual cycle. When did you stop? When did you get menopause? How many biopsies have you had? All the questions. And it'll calculate your 10-year and your lifetime risk for breast cancer. And that way you can take that to your doctor and say, listen, I calculate I'm at 22%. And I don't know if it's, entirely correct, and they can recalculate it. Right. But these are tools that your doctor can use. And if your doctor is not using them, you can use them and advocate for yourself.
Right.
That is what's important.
Excuse me. So when my aunt and I did our gene testing, I was back at a facility. My team was at a local hospital here in Washington, D.C. And I remember saying to the genealogist, I need the most, I want the gene test that's going to test everything. Like I want you to ask me questions from the time I was born until today. And she laughed and I said, it's not, she said, so you've done your homework. I said, ma'am, I am my homework. We have to make sure that people are understanding because what are the chances of you having the Gale one, if I've said that correctly, and that one is okay, or it's not as many questions. So, and then you have the Cusick one, and the Cusick one also said, oh, you're at 25%. But this other one says, oh, your percent isn't that much. And when you go to have these genetic testings done, the doctor, when I go in to see my oncologist, she said, okay, well, I'm going to put your risk in for A, which is the Gale, and I'll put your risk in for B, which is the other one. And I told her, I don't care where you put my name. I'm not a gambler. So if the odds don't sound right to me, let's go ahead and get this taken care of. I don't want to be on chemo forever. I want to be able to enjoy my life, enjoy my children. And a lot of times some providers, not you, Dr. Gary, but some providers are only trying to piecemeal you information.
Yeah.
You have to stand up for yourself. You have to stand up for yourself and be your own advocate. And if you don't think you're getting the right information from your doctor, you got to go ask somebody else.
That's right.
Because
it's true. And you really should ask for a genetic specialist. Prior to my having a nurse practitioner who's trained in genetic counseling, I did all the counseling myself. So in between surgeries, I'd go to the office and I would do genetic counseling. I'd do the pedigrees, sometimes by hand, and go through them with patients. And every hospital, every accredited program really should have something like this. At this point in 2020, every hospital and breast cancer program that is accredited has a genetic component. There is someone they can send you to who can sit down and tease out these things with you so that you shouldn't have to do it yourself. I want to circle back to Lula. There was something else that you said. You made so many great points. And I know we got to take a couple questions too, Ricky. But when we talk about prevention, somebody asked a question and said, well, what do you do if you are high risk? Are there things that you can do? And so it's important for people to know that there are preventable and non-preventable risk factors. Yeah. We can't prevent our genes. You can't prevent what you inherited, right? You can't prevent the number 1 and 2 risk factors for breast cancer, being a woman and getting older, right? Yes. God willing, we'll keep doing both, right? Getting older and being a woman, if that's what your choice is. Right. So you can't prevent that. You can't prevent when you started your cycle or when you went through menopause. Things that you can control: diet, exercise, smoking, alcohol. Those are really super high risk factors for breast cancer right now. What you put into your mouth is probably one of the highest risk factors for breast cancer. How much you move your body is something you can control. Whether or not you smoke is something you can control. So there's preventable risk factors, and that's what I work on in my high risk program. So I start there with patients. Where are we with our weight, our BMI? Where are we with our diet, our exercise? Are we smoking? How much alcohol? How many glasses of wine do we have per week? No judgment here. But guess what? Hey, listen. Right.
It is what it is.
Enjoy quarantine.
I had sparkling water today. But
good. See? And then we start tackling those. And then there's a pill you can talk about. Terry, you mentioned tamoxifen. Tamoxifen can cut the risk of breast cancer in an unaffected person who's high risk if they choose to take it. It can cut that risk by 15, 20%, almost 25%.
And that was my choice as well to start taking it. But by the time it got approved through this HMO, through this MCO, unbeknownst to me, it had been a couple of years. And so I had already had breast cancer.
Right. So,
I'm just taking it now because that's what you're supposed to do. I take it every day. I feel like there are not enough options once you've been diagnosed, or in between me being high risk because of my family history and me being diagnosed. There's just not enough options that they are allowing.
But there are some options now, and they call it the Angelina Jolie effect. But there's such things as, and they call it previvors. I'm sorry.
Previvors. Yeah.
No, it's a previsor.
Previvor. And
like
so that's someone who, has been genetically tested and has made the decision that they are going to do some pre-preventative actions. Some women have their breasts removed. Some have their ovaries and their fallopian tubes removed. And some take the medication. There are some women who are you know, as you know, a lot of younger women are being diagnosed now, 20s and 30 years old. So with taking the drug, there's a chance that they may not have children later, or has that changed? There's some things with that they don't want to do that because they want to have a family. And there are side effects from taking those medications. Not everyone is the same. So I just wanted to share, for me, being that I said, you know, I'm 3-time survivor. If I knew then what I know now, yes, I would have done some things a lot differently. Like when I was first diagnosed, I just had, you know, my left breast, it was the left breast, just some cells, at stage 0, but they were scattered around. So the recommendation was a mastectomy. And, you know, I had that done. It was stage 0. And a year later, the right breast was some cells, but I was in that mindset. I didn't want to lose both of my breasts, but, you know, they could do a lumpectomy, give me radiation. I was cool with that. And, you know, I went on, had my son. I didn't take the medication. I wanted to have children. I said, give me some time. Almost 15 years later, you know, on the incision, I had a lump. I thought it was something with my implant, not thinking that something could come back on the incision. I guess some cells were left there. Actually, they consider it a separate cancer, but that was a lumpectomy removed. And then that's when I did the option of having everything taken out the right, especially since, you know, I mean, I could get, you know, some women opt to have implants, some don't. I opted to. And I had my ovaries and fallopian tubes removed. I just finished taking a Remedex and for 5 years, and I didn't have side effects from the medication at all. But that's me, and I always say everybody's story is different. What everybody goes through, what my journey is always can be different from your journey. But I'm gonna tell you what worked for me, and you Absolutely. Have to find what's best for you, where you're at, where your mindset is. But the main point is look at the statistics and look at how you can prolong your life so that you can live and be here for a long time. It's much they can do now than they could when my mom was diagnosed, when my sister was diagnosed 30 years ago. And here I am 20 years ago, and now my niece was just diagnosed. And there's so much more that she has as far as preventative that she can do. And there's more that we can prepare our children and grandchildren for.
Can I add something in here too? You guys talk about
get in there.
Remedex. Well, I had triple negative. Guess what?
It doesn't work.
So not everybody has access to the drug to prevent breast cancer. And let me just throw some stats at you a little bit. So, you know, the recurrence rate for Black women is 39%. So once you've had breast cancer, you have % of getting it again. So all those things that Dr. Mo talked about in terms of your lifestyle, you have to be doing that. Black women under 35 get breast cancer at twice the rate. So the 1 in 8 doesn't work for Black women under 35, and they're dying at 3 times the rate. And overall, Black women are 42% more likely to die of breast cancer. So really, you know, we can do all these prophylactic things and do it our best, but the most important thing we can do, and that's for everybody, is early detection.
Yes.
Check your breast. I always say check the breast that you love. I know you have a pair. You know, I say that every day to everybody, but we have to, you know, really emphasize the importance of early detection because we don't have to die of breast cancer.
Right. I love that you said that, Ricky. You know, early detection is important, but also focusing on prevention because, you know, how many of us would rather prevent than even detect early? And so prevention for us looks like using what we know. It looks like recognizing that we need to get better rest. We need to eat better food. We need to do exercise and take care of ourselves and do things in moderation. And not to mention just the stress that our environments and our lives, you know,
I was going to mention environmental,
You know, the stress and anxiety will kill you faster than breast cancer. It will kill you faster than breast cancer. Because why? What happens? We see these images right now. I'm wearing my Black Lives Matters. My Black Lives have mass and occupy space because Black Lives matter, and they don't seem to in the news right now, you know? And so we internalize this stuff, right? And guess what it does? It keeps us up at night. It makes us anxious. It turns on stress genes, cortisol, the stress gene, right? And all of a sudden our bodies are in fight or flight. Our bodies aren't processing our sugars right. We're not processing, you know, we become insulin resistant, right? We're not sleeping well. We're our bodies are not processing our food and our metabolism, and we're making mistakes in our cells. And that's all cancer is. It's cellular mistakes, one after another, after another, after another, that gets compounded. And so we have to protect our peace. It literally, our lives literally depend upon it. Our lives depend on it. You know, and so as we talk about prevention, it looks like, you know what, I'm going to have maybe 3 drinks this week. And, you know, I'm going to kind of watch my diet and increase my fruits and vegetables. And maybe I'm going to start to add on, even if I can't go to the gym, I get my water bottles. I'm doing my arm circles.
Yes.
You know, I tell my patients, if you can do the 5 minutes or the 3 minutes of a commercial break, watch 1 hour TV. Don't do the Hulu and fast forward through the commercials, right?
Right.
1 hour of American Idol. Get your water bottles out and do arm circles during the 3-minute break. The next break, do leg lifts, scissor kicks, right? For 3 minutes. You won't make it through 3 minutes. You're going to be mad at Dr. Gary, out of breath, right? But if you can exercise fully through the commercial break, you will have gotten 20 to 25 minutes of exercise without leaving your couch.
Right. And for me, like you said, it's mind, body, and soul. Feed them all. Positivity. Get some, you know, I see a homeopathic doctor as well as regular doctors. And if mentally, if you need someone to talk to, reach out, join a group, or reach out. There's wonderful groups on Facebook now, and there's doctors out here that can help you through stressful things and stressful things. And I exercise, and I do exactly what you did say. I have to like get rid of the noise for most of the day. My TV doesn't come on until like 8 o'clock, and then it's on for maybe 2 hours, and then it's off. And most of the time, you know, people who know me, they're like, what are you doing? I'm walking, I'm exercising, I'm trying to grow stuff on my deck. And, you know, I'm, you know, trying to feed my, you know, I'm praying and I'm meditating, I'm doing yoga. I'm trying to feed my mind, body, and soul, because that makes, that's for your overall healthy, perspective, healthy body, healthy everything.
It's and the source of wellness.
Yeah, it's the source.
Exactly. Breast cancer taught me, I had to learn from breast cancer that my peace is non-negotiable.
Yes, say it again.
Yes.
It's non-negotiable. I will hang up the phone, leave the room, see you, bye, I love you, gotta go.
And life will try you, Ricky. Life will try you. And it will
not just
everything in your path.
Right, absolutely. I went through a situation not long ago. When was it? January, Ricky?
Yeah.
I had no peace from the time I came home until I had to change my situation. I had to take control of my situation and take myself out of an albeit maybe comfortable in some sense, excuse me, but not comfortable as it pertained to my peace of mind. And it was the hardest thing I had to do. But I can tell you, having made my peace non-negotiable, like Ricky has taught me, Tallulah has taught me, Dr. Gary has taught me, what making my peace non-negotiable, my whole life has changed. If I'm worrying about something, it's because I'm choosing to worry about anything that if I can't control it, guess what I do? Walk away from it. Because it will infest you. It will kill you quicker than cancer.
Right. Or it will give you cancer. I believe mine was caused by stress.
Right.
So
absolutely.
And Tallulah, I love what you said. You know, you said I see a naturopathic doctor as well. And this is the thing, as a people, we can walk and chew gum at the same time, right? It's not either or. It doesn't have to be I'm either going to take herbs or I'm going to take medicine.
Right.
We can use every tool that is available. And one of the key messages that I need for us to get is that we can learn how our food is medicine, how our food can prevent disease, how our food can increase our wellness, but also that if we need a surgery, guess what? Sometimes we got to do what we got to do, right? We don't stick our heads in the sand, you know, when we feel a lump. We can be proactive about it. We can be empowered about it. And if people get nothing else from this, I hope that they feel empowered to talk to your family members about their cancer. If you are a person who is reluctant to share your cancer with your family, I understand that there are a variety of dynamics, but understand that we're as sick as the secrets we keep, and the things that you are keeping to yourself about your history, about your medical history, will affect your children, will affect your grandchildren, will affect your great-grandchildren. And you have an obligation to your family to share those things. However you're comfortable doing it, you need to share those things, because we need to be talking about these things. We need to be advocating for these things, because there are so many of us now who meet criteria for testing. We didn't even get to talk about who should get tested, because the American Society of Breast Surgeons, of which I'm on the board of directors, now has a memorandum that we put out, a guideline that we recommend every woman with breast cancer should get hereditary cancer counseling, family history risk assessment, potentially testing. And we're working to get insurances to cover that for every breast cancer patient. It's not happening yet, but that is where we're headed with this. And so what that means is if you had breast cancer in 1987 and you were 35 years old and nobody talked to you about any kind of gene, guess what? You need to go to your doctor and you need to get tested. We need to have clinical trials. We need to talk with our companies, our genetic testing companies. And this is one of my personal missions, is to partner with our companies so that we can begin to look at Black women and our hereditary mutations and find out why are we dying of it worse if we have the same rate of mutation as others? What genes are we looking at? My friend Jasmine, 29 years old, died of metastatic breast cancer. She didn't have a mutation in any of the genes on the panel. I know another young lady who was diagnosed at 17 years old, no mutation, which means guess what? There's a mutation that probably hasn't been discovered yet.
That's specific to African Americans.
That's specific to African American.
Right. But right now, Terry, the more genes we test, you want the long panel of 80 genes. We only know what to do with about 20 or about 40 of them. And the rest of them, we get these variants. Well, the problem is we get these variants in the genes because we haven't found enough people who have the mutations in them yet. And that's why we need Black women to test. We need to develop some programs where we are testing us en masse so that we can figure out what's in our genes. Because we need to understand why we are getting what we're getting. If BRCA 1 and 2 is the same rate as white women, right? Then what are the other genes? What else are we looking at? And if you don't come forward, if you don't talk to your doctors about this, you may not get offered this testing. It may get lost in your medical history. Your family members won't know, and they should be tested. If you have a mutation, your family members need to be tested because there is a 50% chance your children could have it, depending on the gene. There's a 25% chance your siblings could have it, depending on the gene. You got to talk to your folks.
Right.
I got
soapbox. I'm off.
I just did the long panel a few months ago, and Dr. Regina called me to say, okay, Ricky, you don't have any mutations. And I said, well, is that a good thing? And that's good, right? She's like, I don't know, because we don't know about Black people. So there's nothing for Black people here. So I don't know if it's good. So it just means you don't have the mutations that we're testing. So we don't really know. There's so much unknown about Black women and our physiology. It's so important.
Yeah, representation matters. It's a call to arms. All the Black oncologists, Black surgeons, Black doctors, Black women, Black family members, anybody who has been affected by cancer. We need to start talking about these trials, and we need to stop being afraid of clinical trials and start being in them for ourselves so that we can characterize our cancers and come up with better cures. That's the only way it's going to happen.
Absolutely.
Hashtag Black breast cancer. I want everybody to use that hashtag. Hashtag Black breast cancer. We have to put a movement together to make that.
And when you share this live, because we hope that you will share it with everybody who needs to see it, hashtag Black breast cancer for sure. Hashtag the doctor is in. What other hashtags? So Lula, what's the hashtag for your organization so we can tag
hashtag 242boobs. Take 2 minutes to check your 2.
And can we follow you on Instagram and other social media there?
Yes, I am on Instagram and 242boobs Facebook page. This is should be on there right now.
I love it. Terry, how about you? How can we follow you? How can we interact with you? How can we ask you more questions? How can we love up on you?
I'm just Pixie Dust, PIXEYDUST on Instagram, Twitter, and Facebook.
All right, Ricky Fairley, how can we follow you? How can we see what amazing things you're doing and read all these great articles that you're writing, cranking out left and right, doing it, burning it up?
Get the word, trying to live my purpose, Ricky Dove, at Ricky Dove, RICKIDOVE. So
I love it. And you can follow me on Instagram, Facebook, Twitter, LinkedIn. I now a new YouTube channel at Dr. Monique Gary. So please do log on. We want to hear your comments. We want your questions. We want to continue this dialogue for sure. Any closing remarks, Ricky?
Next week, we have a great show next week with some breasties who have turned their breast cancer experience into businesses that support women with breast cancer. So we have 2 breasties about how they channeled their energy and their experience into helping other breasties.
I love it.
So
the week after that, Ricky, we have got to get some of my breasties, some of my doctor friends who have been diagnosed with breast cancer. They are physicians, and they have some stories they got to tell. So when the doctor becomes the physician, will be the following. When the doctor becomes the patient, will be the following week. So the next 2 weeks, you got to tune in Wednesday night, 6 o'clock on blackdoctor.org. And we'll see you there because the doctor is in. We hope it has been real, reliable, and relatable information for you. I love you guys for joining us. Thank you so much.
Thank you, everyone.
Thank you, everyone, for watching.
Remember, take 2 minutes to check your 2. Okay.
2 for 2.
That's right. Hashtag check your chest.
Yes.
2 for 2.
Bye-bye.
bye.